Well, thanks, Naya. Okay, so I'm going to get started on my ICC. This is a case that's actually a few years old. I pulled it from the archives with help from Laurel. That should give you, I guess, a bit of a clue already. Maybe. So the clinical history is of a 60-year-old woman who had rheumatoid arthritis, and she had a single lung transplant for interstitial lung disease secondary to that in July of 2016. And she actually did really well for the first few months, but then in December of that year, she was walking around in New York City and cut her leg. After that happened, she went to the hospital in NYC. They couldn't stitch it closed, so they just let it kind of heal by secondary intention. However, as that was happening, she developed this rash around the leg. So here's a picture of the rash. This is back in April 2017. So it's a pruritic rash, it's erythematous, it's kind of round, and there's some small verrucous areas. And it is right in the area, I mean, it's kind of hard to see on this picture, of her initial scar. And so she was treated with topical ketoconazole and terbinafine, but really it wasn't getting better. And by 2 months later, it had spread to both of her legs and to the back of her neck and her head as well. So at this point, it was time to get a biopsy. So they got a biopsy and they sent it down to DermPath. So here's a picture of the punch biopsy. And on this punch biopsy, it's a pretty deep punch biopsy. As you can see, it's grossly abnormal. There's some epidermal hyperkeratosis. And this is just the other side of the punch biopsy. And as we zoom in, we can see that there's a lot of necrosis, kind of destroying this residual hair follicle. And you can start to appreciate all these giant cells back down here in the dermis as well. And as we start looking closer at these giant cells, we start to see that maybe there's something going on inside of them. I was going to get arrows, but then there's just so many of them that I just couldn't decide which ones to point out. I just got very excited. So more giant cells and more of these round yeast-like structures adjacent and in them. Oh, so there's even more here. These structures are highlighted by PAS, and as you can see these here, they're maybe budding off on each other, kind of a little broadly, perhaps. And then on here, we can see this one has a bit of a double refractile cell wall. There's 2 different layers there. And so obviously, we also got a GROCOT, or they got a GROCOT. And GROCOT stain's usually a little dirty, but even at this power, you can start to see that there are some definite organisms going on in here. See more evidence of this broad-based budding. And then you can see these, which are either germinating yeast structures or pseudohyphae, something like that. So at this point, the case was signed out as deep fungal infection, C note. And in the note, they said that there's broad-based budding, and they don't mention the double refractile cell walls, but that's kind of another thing that would lead us to think that this morphologically could raise the possibility of blastomycoses or other related fungal organisms. Importantly, I couldn't find this stain, unfortunately, but a muci carmine stain was negative. So let's talk about kind of some, other than Canada, what sort of invasive yeast things are possible here. So this is what we have, presumably in our tissue. We have broad-based budding. About 10 to 15 microns in size, which would be consistent with blastomyces dermatitidis. And then this second one here, it's more narrow base. This one will be muci carmine positive. These ones are a little smaller and have that narrow base budding. This would be consistent with a cryptococcus. And then if you have a smaller yeast that maybe some hides in some macrophages, that would be a histoplasma. So when you're studying for boards or whatever, step 1, whatever test you're studying for, you remember that blastomyces has broad-based buds, cryptococcus has a capsule that's muci carmine positive, and histoplasma hides in macrophages and in caves because it's mainly from bat droppings. So as we talked about, this is our agent of suspicion in this case. So let's talk a little bit about blastomycosis. Here's the CDC picture. The environmental form, it's present kind of, I guess, in leaves and dirt, and usually you inhale it into your lungs. And then in the lungs, it can transform from a mold to the yeast form, where it can disseminate throughout your blood. And then it usually likes to infect the brain, as well as the skin is a common site of secondary infection. It's really only localized in a few areas, classically the Ohio River Valley, but it's also found somewhat more sporadically in places in Africa. Here's what it looks like if you were to grow it up on culture. It grows pretty quickly in about 3 to 4 days, and you see this fluffy white mold, and you see these smooth conidia, just single on the ends of the terminal hyphae. More pictures in tissue, just couldn't get enough of these double reflectile cell walls. And so I guess kind of the question here is, she had this trauma to her leg. Could this be some sort of primary inoculation that caused blastomycoses? And this is when I was trying to Google primary blastomycoses of the skin. This was kind of the big paper that came up back in 1983, which talked about several cases that actually occurred during autopsy where pathologists cutting blastomyces infections infected lungs got some localized cutaneous infections on their skin. But in this case, she has a lung transplant. She first presented with this, clinical finding of a rash on her legs, but I guess we still haven't really ruled out where it came from. Did it come from the lungs? Did it come from the skin? And so here's a picture of what either the primary cutaneous or the secondary disseminated blastomycoses infecting the skin might look like. So let's go back to the patient's history. Let's try and put this together. So she actually didn't have any known exposure history in endemic areas. She really hadn't been outside of Philadelphia and New York. So that was maybe made the diagnosis a little more questionable in that regards. But she's not the only person represented in her body. She got a lung transplant. So they went back and looked at the lung history, and from her lung, really no exposure history to blastomyces, and it had negative cultures initially. And then, they obviously did a complete rule of systems, examined the patient, no pulmonary, no CNS disease, no systemic symptoms. And then the next thing that really kind of goes against blastomyces would be that she got a blastomyces antibody test by immunodiffusion, which was negative. That doesn't completely rule out the infection, however, because it's really it's positive in about 80% of cases with active infection. So it still means 20% of people with known active blastomyces could have a negative antibody test here. So let's go back and look at these broad-based budding yeast, which is what we were so suspicious of.
What about the narrow ones?
Yes, well, these ones here, these kind of going off here. Yeah, interesting. So one thing I kind of wanted to bring, I know everyone is aware that, broad-based budding yeast and, other cell forms can look different depending on which plane they're cut in. So maybe they're just two yeast forms that are kind of close together, and if you cut them differently, they wouldn't quite look like they're broad-based budding. So that's, yeah. This is actually a case where Coccidioides was identified as Cryptococcus. I'll talk about that more later. So at this point, she was started on oral voriconazole because she doesn't have disseminated infection. Even if she did have a little bit of disseminated infection, they often are using, I think, voriconazole for blastomyces currently. And so her skin was rebiopsied for fungal culture. And this was all within, a week of this happening. She is a lung transplant patient. A diagnosis of systemic blastomyces would be a big deal for her. And so once that was collected, they actually isolated Trichophyton rubrum. And so this looks weird. This is not a yeast. This is a dermatophyte. It's the cause of athlete's foot, tinea corporis, and really kind of looks like, if you remember that initial picture that I showed you of her rash, it looks like that. So this is making clinical sense. And usually this kind of stays up here. It stays in the stratum corneum. It doesn't usually cause invasion into the dermis of the skin. Here's what it would look like on a lactophenol blue stain. You see these large cigar-shaped macroconidia and the smaller microconidia. And here's how it grows in culture with this white to red wine appearance. So invasive trichophyton can happen, and it usually happens in immunocompromised hosts. I just want to talk about, it kind of can look weird. So in areas of necrosis, which we had a lot of in the skin biopsy, hyphal forms can swell and kind of degenerate. She did get prior treatment, so she got ketoconazole, which has some action on the fungal cell wall. And so if you have treatment on the fungal cell wall, then the forms are going to look differently as well. And also you can see these hyphae. This is kind of the only picture I could find of a definite invasive trichophyton in the literature. They're kind of globulous and they're kind of round. And depending on how they're cut, they could look a little weird. So apparently this wasn't the first case where people were like, oh, maybe it's blastomyces, but it wound up being Trichophyton rubrum. This is, when I just Googled this back in 1998, someone had a case report of kind of the exact same kind of diagnostic dilemma. And so I just wanted to highlight this paper, which really compared fungal histology and fungal culture and how well we are at identifying fungal organisms and speciating them on histology. So this is a review of 10 years at Stanford from 1997 to 2007, so a while ago. And they only had 47 cases where they actually had the forms on histology and the form and a fungal organism that grew on culture. And they actually incorrectly identified it in 10 of the cases, which is a pretty big number. And it really didn't depend on which pathologist it was. You know, over 9 pathologists were here, 13 pathologists were here, because it's kind of across the whole department. And so after this, what they did was kind of come up with a more standardized template, which was, you know, more wishy-washy and saying that we can't really explain one thing or the other with yeast forms as well as, you know, aspergillus and other fungal hyphal forms. So yeah, my take-home points. Blastomyces dermatitis, this is broad-based budding, double refractal cell walls. It causes primarily pulmonary disease, but can go to the skin. And then, you know, in a post-transplant immunocompromised setting, always look for organisms that maybe are not usually invasive, they could be invasive. And speciation of fungiforms on histology is difficult. And you know, if there's treatment, there's necrosis, the forms can look weird. It's really kind of hard to figure that out without culture or other molecular tests. And as always, you know, everyone knows you have to correlate between the clinical laboratory findings and patient history. Some references, and just thanks to Dr. Glazer, who helped me come up with this case, and Dr. Sikor, who was the dermatopathologist who signed out this case, and I think appropriately raised the concern of blastomyces, because that would have been a big deal for this patient. This is where I was exactly 1 year ago today. So.
Sorry.
It's okay. All right, that's it. Thanks.